Tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora and welcome to the first Waikato Palliative Care TeleECHO clinic. It's great to see you all there. We'll begin with some introductions. So what I'll do is call on you one by one and please introduce yourself and say your role. So I'll start with the team labelled Wendy. So Wendy, Carol and team.
Kia ora, so I'm Wendy Carroll. I'm a GP in Paeroa and I'm also Clinical Director for Haraki PHO. Been in Paeroa for far too many years and long-term interest in palliative care. And my team?
I'm Sharon Estevez. I'm GP Registrar here at Paeroa for 6 months.
Yeah, hi, I'm Barbara Lilliger. I'm GP here in Paeroa and in Switzerland.
Kia ora, thank you. And now we will go to Maddie. Go for it.
Good morning. My name is Maddie. I'm a rural CNS and lymphedema therapist and joining the group today with Anne-Marie.
And I'm Anne-Marie from the ARC liaison team at hospice. I'm a registered nurse.
Kia ora, good morning. Tom, over to you.
Hello, I'm Tom. I'm one of the estimators.
Kia ora.
Calling you from the IQ.
And Debbie. Debbie, are you able to introduce yourself? Can you hear us, Debbie? We might. We'll come back to Debbie. William.
Yes, good morning. My name is William and I'm a registered nurse for Te Kurawai Hauora or Hauraki in Thames, Paeroa and Te Aroha.
Morning, thanks for that. And Jane, over to you.
Good morning, I'm Jane Jeffcoat, nurse practitioner at Te Kurawai in Thames. Have had some experience with your team working just recently in Taumarunui, so thank you for this opportunity.
Lovely to have you with us. Over to David.
Hi, I'm David. I'm a GP in Whitianga. I've been here 28 years.
Oh, okay. Great to have you with us. And then we've got someone on the... Oh, that's IT. Cool.
Debbie.
I'll try Debbie. Debbie, can you hear us?
I can see that you're talking to me, but I can't hear anything.
Yeah, we've got support coming to you. Morning. It's Dr. Debbie Barham, one of our trainees here in Hamilton. Okay, well, we will go with our hub team and I'll start with Karen, if you want to start, and we'll go across the row that way.
Good morning, I'm Karen Roberts, team leader for the Community Nursing Service at Hospice Waikato.
Good morning, I'm Andrea Jones. I'm part of the education team here at Hospice Waikato.
Hi, I'm Brian Ensor. I'm the medical director here at Hospice Waikato.
I didn't say my name at the beginning. Lara Hoskins, palliative care physician.
I'm Wayne Naylor. I'm the director of nursing here at Hospice Waikato and lead for the Project ECHO.
Kia ora everyone, I'm Vivian Young, Family Services Manager at Hospice Waikato.
Hello, I'm Charmaine, one of the counsellors for Family Services.
Kia ora, I'm Max Watson from Project ECHO, part of the care doctor from Hospice UK.
Yay.
Welcome to everyone. This is an exciting day. It's been a long time in the planning. Oh, we've got an observer in the corner. And yeah, bear with us if we have some technical difficulties. We've done some practice, but you never know when we actually go live. And so here we go. So next thing to do is just a reminder that by participating in this clinic, you're consenting to be recorded. Do, as you've already done, please mute your audio unless you're speaking. And our tech people here are able to mute and unmute if you're having troubles. Please remember to protect patient privacy. Don't refer to patients by name, no identifying data. but with that, do still tell their story. And just remember no identifiable private health information. And the last one. Oh, yes. We'll try, I didn't even say it again then, I'm Lara. Identify yourself each time you speak, because while we went round for introductions, there was a lot of people, and it's really helpful just to get to know one another a bit more. We've got endorsement from the Royal New Zealand College of General Practitioners for CME credits, an hour and 1.5 CME credits, so an hour and a half, but you'll need to actually be here for all that time. Same for registered nurses, and you'll get a CME or CPD credit sent to you once you've filled in your evaluation. So you send in your evaluation and then the certificate will come to you. Oh, here we go. We've got a strict timetable this morning, so we're going to try and stick to it. And so we've done the introductions. So now over to Dr. Brian Ensor, who's going to speak on choosing your opioid. I'm looking forward to this. So over to
Thank you. It is just a chat about opioids. They have become like friends and colleagues for me over the years as I've tried to get to know them. And so this talk uses anthropomorphism. It puts a face to opioids, which is it's a personal thing. It's not your faces, it's my choices, but it is a conversation starter about opioids, and I think it's useful. It doesn't have all the information that you need. You can get that from the Palliative Care Handbook, from the Hospice New Zealand website, and that's available free to download. So the next slide has my objectives on it. Well, there you go. The recognition of why opioids are chosen and characterisation of opioids. The point of the slide is that opioids may be the brightest bulb in the palliative care pharmacy, but they are not the only bulb. And you are not going to light your whole house by putting a bigger and bigger bulb in the lounge, unless it's a tiny house. You're just going to burn your house down. And so for most of my patients, yes, we do the opioids, but we actually almost always have other analgesics with them. They're not a total solution to pain or to dyspnea. I'm not going to talk about dyspnea. The next slide, I think, is a way of just mentioning the WHO analgesic ladder, which puts the strong opioids after Panadol and the weak opioids. Now, weak opioids probably deserve their own 15 minutes of fame, and I think primary care is probably more familiar with weak opioids than I am, and so I think we need to pick up on them at some stage. BPAC, who advises us on how to live, are very keen that we use weak opioids whenever we can and not strong opioids. Fair enough. Assumed knowledge is really, with the adjuncts, just that you know that tricyclics and gabapentin and pregabalin, they exist. We can talk about them later. So we've got 5 opioids that I want to talk about. All of them are mu agonists, but they are significantly different in my mind. I mean, I grew up with morphine and methadone. Morphine for everybody, methadone for people with renal failure. And then we got fentanyl patches funded in New Zealand, which was very exciting as an alternative for renal failure. And then oxycodone was the next to be funded. Much older drug, actually back to 1916, but well marketed, very popular, and that popularity is getting quite controversial. And the last one is buprenorphine. It's not funded, it's available as a patch, and I just wanted to sneak that in as number 5. So science says that each of these are different in their metabolism, in the different receptors they they bind to, the genetics that's involved, the transport systems that they use. That it's very complicated. It's like, it's not 7:30 in the morning sort of stuff. And so what I've done is just sort of tried to boil it down to how I choose. This is not how we choose, this is how I choose. And so renal excretion puts me in the mind of fentanyl and methadone rather than morphine and oxycodone. Absorption and how I want to use them, whether I want a patch or a pump. Efficacy, I'm going to want to talk about that a bit later. Hepatic, yes, I felt obliged to put that in. I don't particularly choose my opioid on the basis of liver failure, but I choose the dose, but I can be updated on that. And previous experience. So this is a biggie, and let me put the next slide on, which is one of those, oh my God, sort of slides. We did benchmarking across 17, 18 hospices a few years ago as to what drugs were used in the last 24 hours of life. And the blue ones are patients that died in the last 24 hours using only morphine. And so in hospice number 18 on the left, you've got 15% of patients dying just on morphine. Whereas in hospice 2 on the far right, you've got the best part of 70% of patients dying just on morphine, okay? So we're not, it doesn't look like guideline-based prescribing here. It's doctors choosing what they want to choose. The next slide is supposed to be vaguely reassuring because what we've done is to put the morphine equivalent daily doses on each of those hospices. And actually, in the end, we are all using about the same dose. Statistically, only 8 is an outlier, and that previously has never been an outlier. 50 milligrams of subcup morphine is a very steady baseline of prescribing whatever dose, whatever opioids you use. So I'm saying that perhaps which opioid you choose is less important than knowing how to use it. Familiarity is a powerful thing. And so in the spirit of familiarity with these drugs, let me put faces to them, okay? And so this is what I want to do, putting a face to a drug. So this is a very familiar face, morphine. This is Clint Eastwood. He's been around forever, okay? He's done everything. He had a really big gun in Dirty Harry. He rides horses, he drives cars, he directs, he produces. This guy knows how to get the job done. That's why we choose him. He's not that good looking. I mean, he's a bit wrinkled and paunchy, and he's got scars, and we know he has a bad side, and actually that's the advantage. We know the constipation, we know the nausea, we know the nightmares and the delirium, particularly the delirium, and so we know it and we look out for it. Would you let your elderly mother spend a lot of time with this guy? And I'm not sure that I would, but if she was in trouble, this guy would get the job done. That's, for a day or two at the end of life, don't forget him. The next one, oxycodone. Okay, so this looks like a younger, sexier Clint, okay? Also good in a fight, but the sort of person that you might take home to meet your mother. Now, I've got 2 things to say about that. First of all, one day this guy is going to get the paunch and the scars and the wrinkles and all that sort of thing that Clint's got. As we get to know oxycodone, we're going to find out that he's not all sunshine, okay? We get more familiar with his problems, but I think we're still on that road to do that. There are some indications he's nicer in renal failure, maybe he's better in different sorts of pains. Yeah, but just don't idolize him yet. Because the second thing that I want to say about that is that, damn, he is attractive, okay? And so with that attraction carries the real risk of addiction. And I'm sort of starting to get a bit more convinced about this, that you take him home and then you can't get him out of the house. Traditionally, we haven't worried so much about this in palliative care, the whole issue with addiction, but now we're seeing patients who actually we need to get back off their morphine, and they've had something new in flash, and we need to pull back on their opioids. Yeah, I like him. He's a nice guy. Perhaps he's too nice. Think of him as an alternative to morphine, but just don't get too sucked in by this young, sexy image thing. Okay. Fentanyl is the third one. So fentanyl is young and fresh and clean. Fentanyl is short-acting. It's as safe as anything we have in renal failure. The patches are great if your bowel is not working. Your mother would love him. Would he be any good in a fight? Okay. So I'm going to reference the Galway Girl video, if you've seen the Galway Girl video, and he just gets laid out in an Irish pub. Okay, there was just, I don't think fentanyl sometimes has the legs that the potency at the end of life that the other opioids do. Okay, so the next slide does show his bad side. I mean, he's still cute, but the downside of fentanyl, the smallest patch is like equivalent to 30 milligrams of morphine, and I know it's tempting to slap on a small patch, and it is tiny, but actually it is a potent opioid, and we do have problems with even the little patch. Cut it in half. I can't officially recommend that, but I know that happens. And the second thing with this guy is it's a serotonergic drug, and mixing it with tramadol and other SSRIs can cause this restless delirium hyperreflexic serotonin syndrome, and people think it's opioid toxicity, and it's not. It's a serotonergic effect. As we escalate the doses, and it's very easy again to escalate the doses of serotonin, we just need to be careful. So a very useful drug. Not always not my first choice, bit of a niche drug, but certainly useful. Methadone is the next one. So look at this bad boy. Now I'm not, in this small, I'm not quite sure what to say about methadone. Methadone is a mu agonist, it's a strong opioid, but I'm not using it. I'm not using it principally as a mu agonist. I mean, it's like, would you give Edward Scissorhands a gun, or Willy Wonka a gun, or I don't see it as that sort of. I see it as an accompaniment. Methadone is really useful for bone pain and some neuropathic pains, and yes, you can use it as your principal opioid, but it is much more risky and difficult to use, and so I use methadone in a different sort of way. Treat it with respect. Buprenorphine, on the other hand, this is a drug that actually is being marketed for my mother. It is a strong opioid, and all the talk in my medical school about it being a partial agonist and the ceiling of effect is actually it's not being substantiated in clinical use. It's available in unfunded patches, a dose equivalent of something up to like 10 milligrams of morphine a day, which is really quite useful. And Declan Walsh wrote a paper saying he thinks a famous physician from New York, I think, that it should be considered as first-line opioid in palliative care. So that's interesting. But at the moment, I think it's all hat and no head in terms of marketing and theory. Sounds really good, but our practice of it is limited. So those are the 5 opioids that I use. Morphine gets the job done, but we know it's got a bad side. Oxycodone, probably the same, maybe too attractive for its own good. Fentanyl is great, attractive, clean, but I use a lot of adjuncts and other opioids, perhaps to boost it at the end of life. Methadone, different from the rest, use it with caution, and buprenorphine, the unknown, maybe the latest, maybe the safest for the elderly, and there are no questions. There are no questions.
Oh, no, I think we've got a minute or two for questions. So give us a wave and ask a question. I'll call on you if you indicate you've got a question or a comment. Anyone out there? Can we ask who's just joined us? Oh, who has just joined us?
Hi, I'm Martin, GP in Pyro.
Oh, kia ora, Martin. Lovely to have you with us.
Sorry, it took me a while to work it out this morning.
Oh, great to have you with us. And you're in time for all the case presentations, even if you missed much of Brian's talk. It was great. Any? No?
David.
Oh, David?
Can you hear me?
Yes, we can.
Oh, good. No, it's one of my regular things is please don't forget cannabis. When you're talking about, it was fentanyl mixing in with giving you the serotonin syndrome. I'm up in the Coromandel, and so please don't forget cannabis as an interaction, as a lot of people are going to be taking it.
As a serotonergic drug, is it?
I think it is. Doesn't it reacts badly with tramadol, doesn't it?
Oh,
maybe I'm wrong.
Nodding. So
Yeah.
right, there we go. Thank you for that.
Thank
It's
you
really
for that.
useful.
Yeah.
Okay. Well, we will move on to our case presentations. And we have two cases this morning. The first is going to be Dr. Debbie Barham is going to present the first one. So Debbie, I'll call on you.
Hi, good morning, everyone. Sorry I had audio issues before. Just checking you can hear me okay?
Yes, we can.
Thank you. So I'm going to talk to you first about an 87-year-old lady. I know that you have the history there, so I won't just read it out. The questions that I really wanted to focus on were around what the most appropriate analgesia for this lady is, given that she's had a lot of adverse reactions before. And secondarily, how best to manage her breathlessness, which for her is not the biggest issue, but for the son who attended with her was a big question. So this is an 87-year-old lady who appears much younger than her stated age. She attended a clinic appointment with me, accompanied by her son. I had not met her before and didn't have access to any of her other medical records at the time. So she's led a very active life and a little frustrated that she's no longer able to continue doing a lot of these activities because of pain primarily. She's a lady with a diagnosis of metastatic breast cancer over the last 7 years. Essentially underwent her initial treatment in 2011, did very well for a number of years, and then had bony metastases diagnosed 2 years ago. About a year ago now, suffered a fall at home and had pathological fractures to her ribs. At the time of that hospital admission, the rib area and the thoracic spine were radiated with good success in terms of pain management. June of this year, she had disease progression, and the areas of concern symptomatically were in the left hip area and the left ribs again, same area that had been radiated before. So she went forward and had some more palliative radiotherapy to those two sites. She thinks that that helped in terms of the pain in her ribs, but didn't really make any difference to the pain in her hip. Her background medical history is listed there. What is not on that list, but what I suspect she does have, is some asthma and an element of heart failure. Those are not captured as background medical issues in her previous correspondence. Significantly, she does have a long history of osteoarthritis, and in that left hip in particular, she's had that hip joint replaced twice now. The last replacement revision was over 10 years ago. Number of medication allergies, which is really what I always wanted some help with. She has a medical alert bracelet, but of course was not wearing it at the time, so I can't confirm these. Penicillin is the most significant causing anaphylaxis, and a number of opioid medicines causing her significant adverse reactions. I don't have any written history of these reactions, but she is quite a reliable historian. I have no reason to doubt that this did actually occur. From a medical history, the pain is as detailed. The most troublesome coming from that left hip and groin region, and primarily it's incident pain. At rest she's comfortable, but it means that she's having to do virtually nothing in order to keep the pain at bay. The left rib pain is much better. She does have a rotator cuff injury, which she's going to have cortisone to, and then the ongoing arthritis pain in her knees. Other symptoms as detailed, as I said, she's not so bothered by the breathlessness, but her son comments that she makes mention of it every day at home, and he was wondering how best we should be helping her with that. She's otherwise, apart from the pain restricting her function, still really independent and keen to live a very active life. The current medicines are listed there, primarily for cardiac and hypertension issues. She did say that she'd had a bisphosphonate infusion 2 years ago at the time when she was in hospital, but I don't know what agent that was. She doesn't think that she had any reactions to that. From a social perspective, accompanied by her son, he has had a traumatic brain injury and has issues with memory. He's also caring for this lady's elderly husband, whose health concerns probably far outweigh hers. He's much more sick. She has had a lot of time in the past looking after family members who've been dying, and has formed quite strong opinions about opioids on the basis of that, and that if we use opioids it must mean she's dying, the common scenario. Anything else from that history that you guys would like clarified?
I'll turn that over to our spokes. Any clarifying questions? So we'll start with any other information you'd like. No? Okay, at the hub, any clarifying questions? Any further? Max?
Maybe in that she's got to 87, she must have used some analgesics. What has she been using up to now?
Primarily only paracetamol. She used some ibuprofen at some point, but had been told because of her kidneys and heart that she shouldn't continue that. She thinks that did make some difference, but it made her feel quite nauseated, and again she didn't continue it because of nausea more than anything else.
And her experience with opioids, was that a recent experience, or is that 10 years ago, 20 years ago?
All of those reactions listed have been in the last 2 years, so in this time since she's had her metastatic disease diagnosed. She hadn't been using opioids previously for her arthritis.
Thank you.
Good question.
Debbie, can I just ask, has she ever used or considered using any alternative or complementary therapies?
Good question. She does take some supplements, things like chondroitin and glucosamine, but nothing else. She's not attending any integrative medicine specialists, anything other than what's listed there.
And mindfulness, Debbie? Wouldn't consider that.
Do you want to just say your name for everyone?
Hi, it's Charmaine. I'm just thinking mindfulness might be something to think about.
Yeah,
we'll try to go with any clarifying questions, and we'll come to recommendations in a little bit. Excellent. Just trying to stick with our plan. So any other questions to help clarify the case or further information?
How worried is she about her pain, or how much distress? She's obviously a lady who's learned to cope with pain if she's been taking paracetamol, etc. So how big an issue is this for her?
It's not an issue because of pain per se, in that she's quite stoic and I can put up with pain, but it's really limiting her from a functional perspective, and not being able to do things is more of the worry for her. So it has got to the point where it's really restricting her ability to even get up out of a chair and move. So she wants to do something about it from that perspective.
So it's the pain that's stopping her get up and move?
Yeah.
Okay.
Okay, I'm just trying to scan my screen here for other people that might be signalling to me to say anything. Any other question? Oh, who is it?
She was thinking about it, and Marie.
Oh, Maddie and Anne-Marie, did you have something? No? Okay. I'm going to turn it over to you, the spokes, and see, do you have any, oh, I think I like to, I'll just double check what I'm supposed to be doing.
Yeah, that's right. Yeah.
I'm going to,
Any advice or any recommendations?
Cool. I'll go for any recommendations or advice for Debbie in managing this patient. So over to you first, not us, the hub. We want to know what you out there would suggest for a patient like this.
Or if you had a similar sort of experience with a similar sort of patient, somebody like this, what have you done?
I'd actually, because I've had a couple that are, sorry, it's Martin calling here from Viral. I'd probably get her in and come up with a strategic plan that she can see and identify stages of increasing her use of different medications. The nausea from the non-steroidal wasn't well clarified whether it was just gastritis, does she need a meprazole cover? Because if she did well with that and it's the main concern is the osteoarthritis pain, I think that's a good avenue to go from. And there's some really good non-steroidals out at the moment. And then try and identify for her what the next level, the next tier is, and then work around her own literacy or health literacy around what medications are, what she can do with the next stage up, like codeine or tramadol. I don't know if she's a candidate for the adjuvant stuff just yet, plus some of the side effects from those can put people off quite quickly. So I might avoid those at first, but just try to stage her up slowly in a way that she feels that she's in control of.
Excellent. Thanks for that, Martin. Yep, Jane, would you?
Is there the pain neuropathic in nature at all that she might benefit from some gabapentin, for example?
It didn't seem to have a significant neuropathic component. Quite bony pain is more my impression.
Thanks for that, Jane and Debbie. That's good. Good thoughts. Other comments or recommendations? Yep, Jane?
Noticed on the medications, it's paracetamol 500 milligrams QID. Is there a reason why it's not a gram?
So we did talk about that. There's no reason that I could see, so I recommended that she increase that.
Great. Is there anyone who would try an opioid in this lady? David?
Yeah, you might laugh at me, but I would probably out here in the what-wops, I'd probably try a fentanyl patch, but I appreciate you're going to say that once you put it on, it's going to be, it's going to get into the system, and if you have to take it off again, the fentanyl will be around for a little while. But actually, I agree with the other guy earlier. I think the non-steroidals would probably be a better way to go initially, but I wouldn't be too slow in starting a fentanyl patch if I needed to.
David, that disappoints me. I thought you were going to offer her a joint.
Well, you might laugh, but I mean, remember, it might well be coming into your pharmaceutical armory fairly soon. Not many people up here smoke joints, but I'm if they say they might try it, I'm certainly not going to put them off. It's just that I do worry about the interactions.
Absolutely.
Tom?
Hey, yeah, I'm sorry I got called away, so I might have missed some of the discussion, but when I was looking through the case, I was thinking either COX-2s, or, which I think may have been mentioned, so Cellcoxib, or alternatively, pregabalin were having good results, and you can start at a really small dose of BD, so that would be in keeping with Jane's suggestion. And then the other thing was buprenorphine, which I think Brian has effectively introduced into the piece, and it's certainly very useful for frail patients where you're worried they're going to have an adverse reaction to previous opioids.
Thanks for that, Tom. That's good. Or I might ask the hub for other ideas. We'll sort of address the analgesia part, and then we'll come back to the dyspnea part. But are there any other comments on her pain management?
Can I ask, Wendy, what do you do in this sort of circumstance when you're dealing with patients who just can't tolerate our normal drugs? What are your strategies? What do you do in that sort of situation? Is that Wendy?
Wendy, yeah. Oh, Wendy, sorry, can you unmute?
Yep.
There we go for it.
Sorry. So I mean, the discussion we've had around the table here was really along the lines that others have said around trialing the COX-2s. We're just wondering though about the kind of the interaction with other medications, particularly that she's on the dabigatran and already on, you know, a reasonable dose of omeprazole, and so just, I guess, caution around, you know, kind of her gastric and renal issues there. And yeah, we would certainly be cautious about introducing further opioid medication, but I guess it's usually a slow building trust kind of issue.
Good. That's good. William, you haven't said much this morning. Just wondering if you've had any thoughts there.
Not at this stage. For me, it's about getting some indications about where everybody is sitting at the moment, and just thoughts on it. A lot of stuff that I when I work alongside our GPs, just to make sure that, you know, we are working in the right direction. You know, as Wendy was saying, you know, looking at other factors that about the patient themselves and how they're feeling. And, you know, that's the area that I work from mostly, is looking at working alongside the patient, getting them, you know, happy with who you are, and bringing them into a better therapeutic relations, for instance. And so
that's going to be so important in this one. When she's had so many adverse drug reactions, she's going to need some trust there. So.
How do you do that, William? How do you do that when you're, you know, with a patient and you're kind of embarking on something you're pretty uncertain about, whether it'll work, whether it'll not work? How do you get that buy-in in somebody like this, where you're not sure what medication might do? What are your strategies? How do you? Yeah.
Once again, for me, it's about building their trust, and, you know, and getting them involved in their own personal journeys, you know, and getting a buy-in from that perspective. Again, you know, work with the GPs. You know, they're the ones that are prescribing the medications, and so, you know, working with the patient and the GP, for me, is extremely important. But the relationship, again, and modifying what needs to be done and what can be done, what can't be done, but from their perspective, not from our perspective.
It sounds like a really adult relationship with patients, so that it's their choice, their body, and working with them in openness and honesty. That comes across really strongly. Yeah,
absolutely.
Sometimes we can underestimate the value of that. Oh, yeah. Anne-Marie and Maddie? Oh, we're unmuting you.
Hi.
Go for it.
It's Maddie. I was just wondering about heat therapy and other, like Charmaine has mentioned earlier on, mindfulness, and then also there is some certain massage therapies that can be really beneficial if it's done slowly and correctly. And if the person that's knowing the massage therapy, how to do it properly.
Maddie, do you have any knowledge on how you can get that training for a person to know how to do it properly?
Yeah, I have trained in a VADA method, which is different than just the usual lymphedema management, which also enhance that part of massage therapy to manage pain in situations where there are severe and uncomfortable pain.
Debbie, did you have that come up for your patient? Was that something that you talked about?
Massage therapy she was interested in. she doesn't subscribe a lot in terms of psychological interventions, and that she's quite describes herself as quite a pragmatic, practical person, not interested in talking. So it might be difficult to pursue that to a great degree. I did wonder about mobility aids, just practical measures. She's using a crutch, which is not always the safest thing in terms of mobility. So whether she might need a walker or, you know, simple effective mobility aids. I had the same concerns as perhaps Wendy and Sharon about the non-steroidals in terms of her being on a diuretic and an ACE and being 87, and but I did wonder whether topical non-steroidal might be useful, using Voltaren gels, those sorts of things. It's such a localized pain. That might be something. The other question I had was just around the bisphosphonate, which she did have successfully 2 years ago, and we don't have the record of what she was given. It was given in hospital, but perhaps trying to find out what that was and whether that might be something that could help her bone pain, which is opioid sparing.
It's a good thought. Any response to that? Any further comments? Was that someone at Wendy's end? Is that a wave? No. Go for it now. Yep.
I was just wondering, with respect to the nausea, if it would improve changing, if the nausea would improve if we change dabigatran to Xarelto, so rivaroxaban, which gives less gastric side effects, and then if at one stage morphine or codeine would be trialed again, or some opioid alongside with regular anti-nausea tablets. And we were just and we were discussing for this osteoarthritic pain about Zostrix local.
Zostrix?
Yeah, Zostrix, isn't it here? Yeah, the cream.
Yeah.
Oh, the capsaicin.
Oh, yeah.
Okay, and what if you would just talk us through what you would, if you're going to try, say, morphine, what sort of doses would you embark on, and what antiemetic cover?
Oh, I would go very slowly, very, very slowly with a regular antiemetic like domperidone or, So I think that has to be discussed and with the patient, and then I would start very, very slowly to see how she, if she has side effects or not.
And what sort of, because lots of people define very slowly differently. I've seen some very fast. What might you start with?
Oh, yeah, what would you start with? Like 10 milligram doses, or
I'd start slower than
5 milligram.
Like even just using
But you're talking
just like elixir, and just like 1 or 2 milligrams as a PRN, and just kind of, you know, like kind of build her confidence in that medication.
Yep. So that sounds good. So yeah, that's sort of my slowly 1 or 2 milligrams. I've used a 0.5 milligram in some patients before, saying, oh, this might not fix your pain, but let's try it and see if we can get you without nausea.
Yeah.
But other thoughts on doses, or how you'd approach that if you were looking at morphine from the other spokes? No. Okay. And well, the hub team's probably itching and they haven't turned to them. So Charmaine, you were keen to say something. So Charmaine,
Hi, so Debbie, Charmaine. I was just thinking mindfulness is what comes to mind for me. I've had a few clients who have struggled with taking medications and have preferred alternative therapies. So this is just what springs to mind for me at the moment. But it's whether she will be willing to engage in it. It's the problem.
I think it's maybe how it's framed to her. I think if we use terminology that's quite psychotherapeutic, you know, that's going to put her off. But if we talk to her about strategies that will help her pain and maybe don't label it quite so much, she might engage in that. Brian,
having just talked about opioids, have you got any comment, Mr. Ag?
And domperidone if you're not checking around constipation.
Yeah, so if the patient's had nausea, which happens when you initiate and the dose goes up, and yeah, using tiny doses with a bit of haloperidol cover would be my choice. If somebody's had delirium, even with codeine, it's like I wouldn't myself go there. I would use something else. Would I use oxy maybe? Would I use methadone as my sole opioid? Well, sometimes with this sort of person I would, and again, just starting at sort of 1 milligram a day, and I've had a few patients, just these ridiculously small amounts, again with a bit of haloperidol cover. I think the anti-inflammatory thing, the pendulum swings. I've had some, very good responses to people with anti-inflammatories. If you've got this pain and it doesn't respond to radiotherapy, is it possibly an arthritic pain rather than a cancer pain? I throw that in. It made me wonder about an anti-inflammatory even more.
Thanks.
We've really got focused in on the drugs, and Debbie's you were coming across. This seems to be quite a pragmatic New Zealander who's got to her 87 years very well, thank you, without too much hassle, and kind of would like to continue on probably without too much hassle. And her goals are all about her activity and what she wants to do, and it's not so much about the drugs, it's all about being able to do what I want to do. So will medicines help her? They may contribute a bit. Would an OT referral to kind of have a look at ways that she could maybe avail of a little bit of kit in the house to see could she get up a little bit? Because maybe once she gets going, the pain isn't so much of a problem, but it's all about initiation. What's the crack with this lady in terms of what she actually wants from you? And we may get all flustered about the meds, but actually all she needs to be able to do is to get out of the chair, because once she gets going, so it's kind of working out what her goals are. And then I really like William's approach, because I think it's all about negotiating with her the good, the bad, and the ugly, to quote from somebody that we've already seen this morning. But that's kind of the way forward, I think. In this, there's only least worst alternatives. We've got a whole host of drugs, but you know what, this lady in Northern Ireland, what we will probably be thinking of doing, because we've got access, and maybe we will probably bring her into hospice for a couple of days to kind of get it sorted out, with access to the OT team, with access to the drugs, to do all the stuff, to work out a regime which would kind of work for her in a controlled environment. And people say, "Oh, is that a good use of your hospice beds?" Well, yeah, I would hope so, but maybe not. And we are very strange in Northern Ireland, as you can tell from my accent. So it's much kind of putting it into context of what she actually wants, and then working with her. And you've got all those alternatives, but I don't think any one will sort it. I think it's a holistic approach, working with her, what she actually wants to achieve, and she will cope with more pain than certainly I would. Obviously, I'm a male, and we have different pain thresholds, but she will deal with a lot. It's all about what she wants to do.
I think that's absolutely the thing with her. I think function is our in, not pain relief. And so I think the restrictions come that we have difficulty accessing community physio and occupational therapy. So those are the two things that really I'd love to be able to prescribe her, but actually practically accessing them is quite difficult. She may be willing to fund that privately, which might be an option.
Yeah. Oh, William.
Whether in our area we have fund audit teams. Both navigators and clinical nurses that go out into the home as well, and provide other sources of help. you know, whether it be from just going and talking with the person and spending time with them, or even negotiating areas where they can actually mix with other people of their age, like kaumātua groups. You know, those things that I've seen in our clinics especially, that has been a real value for people. You know, I get the fact that then they may have mobility issues, but you know, we have kaumātua groups that meet on a weekly basis, some on a fortnightly basis, and they just get together and they do things. Some of them do knitting or just talk about what's going on for them. And when we start looking at that, you know, that whole holistic approach, you know, we start bringing people in and getting them involved again. You know, making them feel part of something. You know, that seems to be an approach that we see that is very, very beneficial. The other thing too is, you know, comes when we're looking at holistic, is that, you know, I'm a big thing around food and how that influences a person's body as well. So just my little thoughts there.
Great, thank you. I think we might take 1 or 2 minutes just to quickly address breathlessness, and we need to move on to our next case. Any comments from those in the folks about managing your breathlessness? Tom? Sorry, David? David, go for it.
Yeah, I've got a patient just at the moment who's on fentanyl for pain and is quite breathless. So I'm just, I'm interested, I'm listening to you because I've just rung the district nurse to add some morphine to it because I think that would be better for breathlessness. Have I done the right thing?
Oh, I'll let the spokes answer that question first. What do you think? Any comments, any thoughts?
I think getting rid of the cat first might be a help.
What about Wendy and the team there? What are your thoughts on that?
I guess that it's probably very much like the pain, really. It's, you know, how much of this is a problem? How much do we actually need to address? You've talked a little bit about the possibility of the background of asthma and stuff. So is that reasonably well controlled? You know, what actually is the nature of the breathlessness? Is it related to her cancer, or is it related to other underlying conditions that we need to manage better? And sometimes breathlessness is quite a sort of a subjective thing, and you know, patients deal with different amount of breathlessness, you know, in different ways. So it is very much like the kind of the pain issue of sitting alongside her and understanding what her problem is, and then trying to find a way to deal with it. I mean, I guess, you know, that the issues around using morphine here, which in general terms does work really well, but in this particular case, you'd be really cautious about doing that because of all of her, you know, all of the reasons that we've already just been discussing around pain. So I guess it is perhaps more a kind of a conversation, a discussion, a sitting alongside the patient and what really is the issue and how much do we need to address it.
Wendy, how easy access do you have to getting a chest x-ray to see maybe she's got increased widespread chest mets now or something like that? Or is that
so we have here in Pyro, I mean, I could request on a palliative care patient, as long as she's got transport, she could get a chest x-ray, or she could get it today. We would have to send her up to Thames Hospital for that, but certainly within the next week, we would, you know, we can get routine chest x-rays done quite easily. So yeah, so not too much of an issue.
Any value in doing that, or is that overkill? What do you think?
I guess it depends a little on what we, you know, the kind of the background of what we already know, and I guess, you know, in this particular lady, I think it's probably, you know, if breathlessness really is a problem for her, I think it would be a reasonable thing to do to try and help evaluate the problem.
David, you look very upset there.
To get to the X-ray, in what way is it going to change your management?
Yeah, really good question. Really good question. It just might be, you might think of using steroids or
Yes, yes.
If it was kind of lymphangitis, or and it might gear you up into this is actually very much towards a terminal phase of things, and it might save you using medications which actually weren't going to work. But it's all a balance, isn't it? And with her real life situation.
Jane.
So I was just going back to what is the actual nature of the breathlessness? You know, is there an element of thopnia, or, you know, even when she's sitting in her chair, that would give us a possible background of some sort of failure, which of course then you're going to look at a different treatment plan for that. Is it when she's trying to move and that's when the pain is worse and so she gets breathless? She's also going to have I would imagine, a decreasing level of fitness there. So it's not necessarily going to be related to her disease, as in her metastatic disease, I guess. So the chest X-ray may be beneficial to exclude there being some sort of lung mets that could be causing the breathlessness, rather than necessarily, you know, are there lung mets there?
Yeah.
Cool. Now our time has run out and we need to get onto our other case. So I'll just take it back to Debbie. Normally I would summarise the case, but I think we've had a really good discussion, but complex patient, even though it sort of seems straightforward at the beginning. The question of the role of opioids and starting low, re-looking at the simple analgesics like upping of paracetamol, using a non-steroidal, maybe not. Looking at non-pharmacological, building that, as Martin set out in the beginning, building trust, and William reinforced that, and a therapeutic alliance, and going forward based on what's the patient desire. Really good discussion. Debbie, just over to you for other comments. Have we helped answer your question?
Yeah, thank you. It's a good discussion. I think for me, the biggest thing, it's nice just to hear the non-pharmacological stuff that this lady had felt all the way through, that everyone keeps throwing opioids at her. I don't think the answer is in medication. So I think that was really valuable, that we just think a little bit broader than what opioid can she take because she can't take morphine. So thank you.
Thank you.
In terms of the breathlessness, just to reassure people, she's not bothered by it at all. Her son is, and again, it was all about the conversation and explaining what might be causing it and what might help. And I don't think we necessarily had to do anything different. It was just explaining it.
Great. Well, thank you for that. That was really good. Now we're going to head to Dr. Sharon Estevez, who has our next case. So over to you, Sharon. Thank you.
All right, so this is a patient that's just recently come into our practice. She is a lady who has been living with chronic ill health for a long time, but in a different rural town. And like her medical history includes diabetes, obesity, ischemic heart disease, chronic lymphedema, bipolar affective disorder, history of CVA, history of drug, alcohol misuse. And she was living in supported accommodation with quite a high care package for a number of years in Thames, and then was admitted into hospital in August. And we're not really sure why. The discharge summary just literally for a 2-week admission, the diagnosis was social admission, and all we got was a list of her conditions and a list of her medications, and basically said she was well during the admission and she was like being discharged to residential care. So she's come into our practice because she's been admitted into the local residential care home. She also has been seen by older persons, has been diagnosed with dementia, I think possibly vascular, possibly Alzheimer's. And her most recent MOCA was done in April 2018, and she was it was 17 out of 30. So when she was admitted into the care home, she was noted to have quite a lot of GI symptoms, nausea, diarrhea, and had one episode of PR bleeding. And really wasn't clear what was going on. There was no indication that she had these problems in hospital. And we wonder whether she, she may have had an occult malignancy. She was pretty clear that she did not want to go back to hospital. She was quite distressed by her time in hospital, felt that they had not treated her well. And so she said she didn't want to go back to hospital, and she just wanted to stay where she was. And so at the same, around the time she developed some chest symptoms, and we felt that she may have had a pneumonia, and it just seemed that she was generally declining. And she was actually started on a pump with some morphine and haloperidol, but then she stabilized and improved, and she's has 7 children and is only in contact with one of them. She does not have an EPOA. She did not want her any family members to be EPOA. And so we've had quite difficult discussions around given she has a diagnosis of dementia, how do we support her? Because this is not a lady we know. We don't have a good long-term therapeutic relationship with her. We don't know the family members. We have met the daughter once, but she seems to have her own issues going on in her life. She was quite intense around with the staff in the residential home, quite tearful, and sort of saying that she wants her mum kept comfortable. But like I said, we don't know this lady. We don't know the family. And how far do we go around her management when we're not clear on the patient's capacity to make decisions, and we don't have a therapeutic relationship with the family. Over the last couple of weeks, she has kind of just withdrawn, really. Even though her clinical condition seems relatively stable, she's become more withdrawn. She's not really engaging with the staff, with us. We did wonder whether she was depressed, and given her background in mental health issues, we asked old person psychiatrist to review, which she did. She felt that she wasn't depressed, and but at the same time, sort of said that the psychiatrist said to the nursing staff, if you don't feed her, you're going to kill her. And that left the nursing staff quite distressed. The patient's refusing food. She drinks a little bit, but I sort of said in the case that she had some nausea, vomiting. She didn't have any further symptoms, but she has actually had some further nausea, vomiting. So she's drinking a little bit. She's refusing food. She's variably taking her medications, and she just kind of spends most of her days lying in her room with her eyes closed. And so what the challenges for our team have been, helping, we're really not clear what the timeline is here, what's going to happen, how long it's going to be. There's no clear terminal diagnosis, but she definitely seems to be declining. And it's helping support the family with what's happening, helping support the nursing staff in the residential care facility, and decision making around someone who has reportedly had dementia, who has clear evidence of that on a MOCA. How far do we follow her decision making and a patient we don't know and family members we don't know with no EPOA?
Wow, what a challenge. It's a good, tricky one for us to all consider. So we'll start with clarifying questions. So, and before we get into advice to Sharon, just want to see, are there any questions? Have any more information you want? Give us a wave. David.
Oh, I wasn't really waving, but
sorry.
no, that's fine. I've got a very similar patient who is unfortunately 10 or 15 years younger than this one, who's turned her face to the wall. So I'm listening for any help you can give me. So can you just remind me, had she had any antidepressants? I mean, that psychiatrist was obviously totally unhelpful to say something like that to the staff. God.
In the discharge summary from the hospital, she's not on any antidepressants. The psychiatrist suggested starting some mirtazapine to help with it.
Yeah. Did you do so, and did it help?
She's not really taking her medication, so.
I've got some way out things, but I'd like to listen to some more reasonable things. And it's not cannabis, all right?
So other questions for Sharon? Clarifying questions? Tom? Oh, we unmute first, Tom. We can't quite hear you yet. Here we go.
And again, I'm sorry, I've been popping back and forth, so I missed a little bit there. When I was reading the summary.
Oh, Tom, sorry, we can't hear you. We've got a big concrete truck outside that's pouring, so it's quite difficult. Are you able to?
Speak right into the microphone, nice and loud for us, Tom.
Sorry, I'm sorry if I missed bits of that because I'm popping in and out. But I think when I read last night, so the psychiatrist didn't feel she was depressed, and a psychogeriatrician had reviewed her as well. So it sounds like you've done everything that I was thinking of. In these circumstances, when people say, well, has the lady got capacity? It's very difficult to assess capacity when they're not communicating, isn't it? Yeah. And I think I would just wanted to express what a difficult situation.
Yeah, good on you. Yeah. Okay, others faced a similar situation or any questions?
Just one question with regards to capacity. When you talk to her, do you feel as though she's able to, like a mocker of 17 means that she may not make it back to the supermarket, but she knows if she likes potatoes, she knows if she likes roller coaster rides, she knows that she doesn't like people. And did you get a sense that she was able to make that sort of decision? Like her wanting to die, did you feel as though that was something that she's sort of not wrong about?
I think we have the sense that she's just wanting to die, but she's not explicitly stated that, and I don't know that we've asked her that explicitly. One of the GPs who's seen her felt that she was kind of okay, I know it sounds crazy to say, but she was kind of okay to make those decisions. She did come across as knowing her own mind, especially when he was having discussions with her around returning to hospital. She was so clear about why she didn't want to return to hospital and was able to give a good reason in her, around being mistreated, basically.
Because she clearly knows what she doesn't like.
Yeah. That's a good point. Yeah. Thank you for that. Are there other questions from the spokes?
Yeah, I've just got one more actually.
Yeah, go Matt.
This is a question for everybody, not really about the patient, but we have to keep everybody alive.
Yeah.
Why do we have to keep everybody alive?
And absolutely, Marty. And I think that that's kind of one of our eternal kind of issues, really, isn't it? That we spend a lot of time being trained that we have to, preserve life. We have to do all of these things, and so it's quite a turnaround to stop and have a conversation with patients about, you know, is it okay to stop treating? Is it okay to accept that, you know, we can't make these things better? But I guess the issue here is does she really have the capacity to make that decision, and how do we address that?
But I was just thinking, even if she has not got the capacity, all you're left with is tube feeding, which is barbaric.
Absolutely.
So at that point, I'm thinking, that's the outcome.
Yep. Yeah. Good point.
And from a Māori perspective, we would sit with the old people and just, if they want to eat, they eat. If they didn't want to eat, you let them go.
Yep. Yeah.
We don't push food in, or, you know, like when they decide to stop taking their medicine, we stop. I've got patients in renal dialysis, they say, I'm going to die now, that's it. And I just, okay, sweet. Let's do this, and they'll look after you until you go.
Oh.
I think I would agree completely, you know, and I think that's where we are with this lady, trying to support her. But as a team, and I'd say as a team in a wider, capacity, that includes the psychiatrist. So the psychiatrist coming along saying to the nursing staff, "You're going to kill her if you don't feed her," is not helpful as a wider team.
We will be doing that. I would tell the psychiatrist, yes, that is our plan. We're going to let it on.
Sharon, is there anyone else? Oh, sorry. Oh, sorry, Martin, you're coming and going. What's it?
Well, in one sentence, the psychiatrist is saying, no, there's no depression here. And in the same sentence, gives him morphine. That's like...
Yeah. Maddie, you want to say something? And then we'll come to Tom. Oh, just wait till you're unmuted.
Okay, it's Maddie. I worked in the rest home many years ago as well. And with this lady, if she hasn't got, we don't know what her mental capability is to make decisions, but she has got only one thing that she can do, that she's got power, and that's not to eat.
Mm-hmm.
And if she doesn't want to eat, then I think it's wrong that we take that power away from her and we'll take her medicines.
Oh, thank you. Tom, you had something you want to say, and then Debbie will come to you.
I think these are worst case scenario. Capacity is always best assessed by the people by the practitioner who knows the patient best. And I think you clearly identified the first problem, that this lady's fresh to you without a background or history or relationship or rapport. What I would say is that, I think, echoing what other people have said there, we need to be very cautious that we don't add something in that makes her unhappy. In that you've done everything I could think of, in that you've asked to assess for depression, or certainly significant depression affecting her thoughts. You know that she's got mild cognitive decline. Is this a rapid dementing process, in which case the lack of oral intake is a natural progression of her disease? And we know that feeding in severe cognitive decline doesn't extend. So I think it's building that consensus of opinion, backing yourself with second opinions from the relevant party, so that really everyone's talking with one voice. But I completely echo Martin. You've got to be so careful that you don't do something here which is actually going to affect this lady negatively by our intentions. Yeah.
Thanks, Tom. And Debbie?
Thank you. I was just sort of reflecting, yes, this is really tricky. We feel like we own this because we have this responsibility as medical people. But I really like the approach, and I think William was talking about before, about involving community, that this lady needs to find some meaning in the time that she has left. And are we always the right people to help her find that? Might it be that there's some kindergarten group that needs to come in and sing, and she's going to engage with them, or looking outside of the medical context? I'm not sure in the medical model that we're going to find answers to these things. I think it's when we identify with this woman as a human being and finding, what's her connection. Is it music therapy? Is it having children in the rest home? Is it, she's been moved from her way of being and her understanding of life, and now we're coming at her from a medical angle, wanting answers about this, that and the other, and I just wonder if that's even the world that she's existing in. So we have to look outside our model. That's my thought.
Great, thank you for that. Jane, you haven't said anything for a little while. Have you got any thoughts on this one?
So it's a bit out there, especially if we, you know, want people to have healthy diets and that sort of thing. But, you know, just going from my father who had dementia, towards the end of his life, he refused a lot of food. And he just ate the stuff he liked, which tended, he had a sweet tooth, and that's what he was interested. You know, if you gave him a bit of pudding, he'd scoff it down, and otherwise he pushed anything else away. So that's the other thing, that we don't know this lady. You might not know what her likes and dislikes are with food, but perhaps just to give her some sustenance, try and work out, you know, maybe not the food that she's being offered is what she's finding that interests her.
We're getting the sense that you said at the beginning she was new to your practice, but you get the strong sense you've come to know her. The staff do, and perhaps you are rapidly becoming the people that know her the best, which is a lovely thing.
And certainly the staff in the residential home, now it's been 6 weeks, and so they are getting a sense of who she is and what she, and trying to fit in with that really, around her wants and needs.
Yeah, sorry, I'm letting you speak lots, and now I need to let my hub speak. Wayne, to go first.
Yeah, so it's Wayne here. I was just actually going to say pretty much what Debbie said. I am a bit concerned that the feeling is she's not eating, she wants to die. We can't ascertain that, but she's been taken out of her community to somewhere else. She doesn't have good family connections. And again, what Jane said, I think getting to know her and finding out what are the things in her life that she enjoyed doing. Perhaps she's not eating and wanting to die because she has no enjoyment in her life anymore. So trying to find out, and perhaps talking to the people who did know her well, from her previous carers, her previous friends from where she's come from as well, to know what she used to do in her life and activities to get enjoyment, and maybe looking at whether you can bring things into her life now that might bring back some of that will to live and enjoyment in her life. And it might be food, it might be her friends, it might be the carers who were looking after her for 10 years before she moved communities, or it might be, there's an ad on TV that springs to mind of the lady in the rest home that's not doing anything and not wanting any interaction. They bring a kitten in and sort of brings her out of her shell, that kind of approach.
Hub team, others, Brian?
So I'm not sure what to, I know this woman because I went to see her with my palliative care hat on, and she looked very familiar. Now this is a woman with GI symptoms and her liver functions gone off, and she had a cup of tea and vomited some bile, and then she said, I'm just too tired to eat. And I feel harassed by people wanting me to eat. I'm just too tired. She was sitting up and she was engaging, and she certainly didn't strike me as depressed. She struck me as somebody with a gut cancer who we would just treat as somebody with a gut cancer. So, yeah. So in the interest of anonymity and all that sort of stuff, I'm not quite...
No, that's useful, and I think that's been highlighted in Sharon's presentation, and I think it's great because in our discussion we've covered both what if, in this case, there's likely a gut cancer, but in another case where there wasn't those symptoms, how we could approach that. And I think that often patients and her saying, I don't want to eat, I just want to die, or indicating that kind of thing, is just reflecting what she feels inside. She can medically tell that she's getting weaker, and she's just letting you know. And you've got, again, you can't do anything to her. She doesn't want to go back to hospital. If you put a feeding tube down her, which we know is not indicated, she'll pull it out. There's kind of not another option other than caring for her. But it's nice to think what that not doing those medical things, what other things are with it. But Max is itching to say something, so over to Max.
Does David wants to say something?
Just interested in whether you had used ketamine in these situations, because you hear of it being useful for the catatonic patient. I've never used it. I've wanted to in my patient, but I just got laughed at by the psychiatrists. Does that have any role at all? After that, I'm afraid I've got to go, so I'll listen to your answer, but then I've got to go.
I don't think this lady could be described as catatonic, so I think using ketamine in that circumstance would be way out there, way beyond cannabis, I think. But Wendy, what's come across is your real commitment to this lady and your real commitment to the home. It's just so impressive to hear the way you're dealing with this. It's just a couple of thoughts, and one was, if this lady is with a bipolar, then presumably there is a psychiatrist somewhere in the past who has known her, who could maybe get you some more information. Second big thing is that this isn't just about the individual, this is about the family member that she is connected with and the team in the care home. And somehow it needs some sort of discussion all around about setting goals of care, so that psychiatrists coming in can be accusing people of euthanizing this lady. That is so disruptive and hurtful for everybody. The second or third thing is that no matter what decision is taken, there is still a duty of care to this lady. Even if no additional care is given in terms of medications or trying to encourage her with cats or food or local children coming in, there is still an ongoing duty of care, and that can be really difficult for the team in the care home, care setting, unless everybody's on this kind of same point in the story and has got the narrative correct. And I think this is such a contentious issue in New Zealand at the moment, that there are so many narratives around this area, and that people then get onto a high horse about this or that, or supporting this or that. So having kind of really clear discussion about what our goals of care are, and how we're going to deliver and meet those as best as we can. And finally, my one thing that I haven't come across in this sort of situation is that we look for the reversible, and if the reversible isn't reversible, then we go with what the patient is clearly stating. And our medical legal framework is such that unless we can actually prove that somebody doesn't have capacity, they have capacity. That's our Medical Capacity Act in the UK. But we have a worry that sometimes people withdraw if they've got pain. Sometimes people withdraw if they've got other reversible things. So we try the antidepressant for a little bit. We try analgesics for a little bit. But with the background news that we're picking up here from that visit, it sounds like this is a lady who is dying. But sadly, she's been parachuted into you in the last phases, and it's causing anxiety and uncertainty, when actually, when we look, see what her blood results are, see where she's coming from, this is about managing the terminal phase of this lady's life.
Thanks, Max. Viv Young from Hospice. I'm interested in, what Brian has said. Yes, she has engaged at times, but she's also giving some clear messages, and she's closing her eyes with the doctor, and she's closing her eyes with the nursing staff. But she seems to still be with us, obviously. So I want to sit there and ask her what this is like. With a counselling background, a caring staff member from the rest home. I've noticed with my own elderly parents, some caring staff members walk in and out of the room, others stop and engage, and there's particular ones that can engage with particular residents. You get their favourites, they're like family members. And I've got the sense of wanting to know who in the rest home might be the ones that could sit and engage with her and see how this is going for her. It might not be counselling, but it's kind of emotional support and pacing themselves at where she's at. That's what's in my mind. Yeah.
No, I think we could carry on chatting about this case for a long time, but I'm really determined we'll finish on time today. So I think everyone's got a good sense, and Max sort of summarised some of those things, so I'm not going to re-summarise the cases I would. But Sharon and Wendy, does that seem to answer some of your questions?
Yep, we've got some things to take away and engage with the nursing staff. I think it is around just getting everyone on the same page and making sure that everyone is feeling supported and, you know, clear about what's happening with her.
It would be really good if maybe in a subsequent echo you could let us know how things go with her.
Okay.
I'd be really keen to hear.
Yeah.
So the great thing about this with our echoes is that we can do that longer term, make some recommendations and just find out how things pan out.
Yep.
So with that, do I have any volunteers to present a case for next time? It doesn't have to be really complicated, just someone you're seeing. Anyone? The plan is that I'll speak on dyspnea next time, and our next session is on the 18th of October, same time, same place for us, but you can be anywhere in the world. The wonders of Zoom. I haven't seen any way of saying you'll present, but do really think about presenting a case. There's something about a case, your own case being discussed. Hopefully we're friendly and it's a supportive environment, so do that, because that's the heart of ECHO. Any questions?
Was William nodding there? Was William nodding?
Well,
I wondered myself.
We'll just unmute you.
Can I just say something? You know, one of the things just about that last case is that, you know, one of the things nobody really discussed was that this woman has got 7 children, you know, and she's only dealing with 1 at the moment. You know, so you know there's a lot of history that I've seen with, you know, where parents, you know, they want to engage, but they don't know how to after a certain time. So, you know, has anybody even discussed this with the rest of the family? So that was my little piece in there.
Oh, nice. Thank you for that. Would you like to? Do you have a case that you could tell us about next time?
Maybe.
That'll do for me.
Maybe.
Cool. So we are happy for you to let others know, particularly in your area, Paeroa, Hauraki, around the Coromandel. We're keen to get others part of this. This is, so do talk about it, let people know, and there's going to be an increasing amount of information, hopefully on the hospice website. So we're trying to get that up and going. Do fill in your evaluation forms, and Andrea will, in exchange for that, send you your CME time certificate. Was there anything else that we needed to say? Okay, well, yay, that was the first one, the first live one with GPs and nurses and nurse practitioners. It's awesome. So, kia ora, thank you all for being part of this. It wouldn't be ECHO without you. Thank you to all the participants here at the hubs as well as the spokes, and we look forward to seeing all of you, or as many as possibly can, next month on the 18th of October. Ka kite.